So the last topic that we are going to talk about is the adaptations in the renal and urological systems during pregnancy. So we talked a little bit about this, that the renal system must adapt because there's an increased need for excretion of waste. So the adaptation in the renal system is to meet the needs of the expansion of mom's blood volume and increase waste production. The predominant hormonal influence is the relaxation of smooth muscle by progesterone. Okay? And this is a theme that we will come back to over and over again. Progesterone relaxes smooth muscle. Now, because progesterone relaxes smooth muscle, we see structural changes in the urinary system. We see something called physiological hydroureter and hydronephrosis. So hydroureter is a dilation of the ureters and the urinary tract. Hydronephrosis is an enlargement of the kidneys. And the enlargement of the kidneys is also due to the increase in renal blood flow. Okay, so the kidneys get bigger because we're sending more blood there and it enlarges it. The ureters also elongate, right? And it's because they're getting displaced by this growing fetus. Okay. We also see decreased muscle tone in the ureters and bladder, which causes bladder capacity to double by the end of the second trimester. Now, that's going to be important because as the baby starts to impinge on the bladder, sort of pressing on the bladder, that increase in capacity, that relaxation of the bladder, is actually going to help increase the time between needing to urinate, even though it's quite small during pregnancy. We also see urodynamic changes. We see an increase in urine output by 75%. Mom is producing a lot of urine. Renal blood flow, as I mentioned earlier, is increasing by 35 to 60%, GFR by 40 to 50%. Okay. So this is just a picture of an enlarged kidney. Okay. And this is, of course, in this picture, the kidney is enlarged unilaterally, but in a pregnant woman, it's both kidneys that are enlarged. And then the hydroureter is the dilation of the ureters leading from the kidneys to the bladder, which in a pregnant woman would also be dilated on the other side. Okay. And then the elongation of the ureters. So the ureters run from basically the lower portion of the thoracic cavity all the way to the bladder, which is sitting in the pelvic cavity. So this gravid this gravid uterus, right, is sitting right here, and it's stretching the ureters as they move down. Okay. So those ureters are not only dilated, they're also elongating, okay, because they're negotiating the enlarging uterine size. So women during pregnancy, in terms of renal function, they have significant changes in their fluid and electrolyte homeostatic systems. Okay. So in general, women who are pregnant have a net retention of sodium in water. Okay. And remember that net retention of sodium in water was the reason why plasma volume, right, increased by over 50%. Now, this retention of sodium and water is a result of an increase in a variety of sodium retaining factors, which I'm going to talk about in the next slide, an increase in water retaining factors, which I'm also going to talk about, and that increase in sodium and water is going to help increase plasma volume, and it's also going to it's going to help meet the sodium needs of mom and fetus, which are considerable. Okay. So this new balance in sodium in mom is achieved really through a balance of factors that tend to promote sodium excretion and factors that tend to retain sodium. Okay, so this is an important concept that mom, so if you go back here, mom has a net sodium and water retention, right? So mom has a net sodium and water retention. That doesn't mean that she can't maintain homeostasis. It means that she is actually defending a new level of normal. Okay, so her entire renal system and electrolyte system is changing so that her body starts to defend a higher sodium and water concentration in her body. So mom is actually achieving a new sodium balance. And that balance, as I mentioned, occurs because of a balance between sodium excreting factors and sodium retaining factors, right? Or natriuretic factors and anti-natriuretic factors. So sodium excreting factors, mom has an increased GFR, right? Mom has a decrease in plasma oncotic pressure, right? And that was because of the albumin concentration being lower in the hemodilution. And because mom has an expanded blood volume, that tends to stretch the atria of the heart and cause the release of something called ANF, or atrial natriuretic factor, which tends to promote the excretion of sodium. So there are these normal changes in mom that would tend to promote sodium excretion, and some normal changes in mom that promote sodium retention, like increased renin, increased aldosterone, the effects of progesterone on the renal system, the effects of estrogen on the renal system, and there's another hormone called HPL, human placental lactogen, that also affects the renal system to promote retention of sodium. Okay. And this stimulation of the renin-angiotensin system is a very important component of the adaptations that we see in mom. Okay. Pregnancy increases the activity of all the components of the renin-angiotensin system. So if we revisit this system, we know that the liver releases angiotensinogen, right? The liver releases angiotensinogen into the bloodstream, and the renal baroreceptors, the baroreceptors that are in the kidneys that measure blood pressure, release renin when blood pressure goes down, and renin converts angiotensinogen to angiotensin 1, and then angiotensin 1 circulates in the body, and then it goes to tissue beds like the lungs that are rich in converting enzyme and produces angiotensin 2, which, among other things, promotes the production of aldosterone and the retention of sodium and water. Okay. So estrogen directly stimulates the release of renin. Decreased mean arterial pressure in mom stimulates the release of renin, and progesterone stimulates the release of renin. Okay. Excuse me. So the maternal renin-angiotensin system is extremely activated during pregnancy. Okay. And so if we consider that angiotensin 2, angiotensin 2 during pregnancy is elevated, right? Now, angiotensin 2 also causes vasoconstriction. So, for a healthy uteroplacental circulation, those spiral arteries in the uterus are remodeled, right? So the spiral arteries, because they are remodeled, are not going to respond to elevated angiotensin 2. Okay? They're going to stay dilated. But you can see how as pregnancy progresses, if you have that preeclamptic altered implantation and the spiral arteries were not remodeled, that as angiotensin II levels rise, you can potentially also have constriction of the vasculature. Okay? So that can contribute to it too. Maternal renal system also has we also see an alteration in the regulation of osmolarity and water balance during pregnancy. And this is actually a pretty significant alteration. So mom is retaining a lot of water. About 70 to 75% of maternal weight gain is due to increased total body water. And the mechanism of water accumulation is not entirely clear. But we know pregnancy is associated with an increase in water retention despite a decrease in plasma osmolarity and plasma oncotic pressure. Okay? Those two things would normally cause you to expel water. Okay? But even though plasma osmolarity is decreased, as is oncotic pressure, we're still accumulating water. So maternal plasma osmolarity is about 273 compared to 290 in non-pregnancy. Okay? Just to give you some perspective, if you as a non-pregnant person went from 290 to 270 within a short period of time, you would be having a seizure. Okay? Because 273 is a very, very low osmolarity. But there are changes in mom's system that seems to support a change in plasma osmolarity, and it does not disturb mom at all. So HCG is thought to play a key role in resetting the osmostat, or the part of the brain that controls plasma osmolarity. Okay? It's thought to actually change the osmotic threshold for both thirst and ADH secretion. Okay? So even though we have all of these significant changes and a very low plasma osmolarity compared to non-pregnancy, we seem to have really a new balance achieved. And so mom's body can respond normally to changes in plasma osmolarity that happen above or below her new set point. Okay, so if you recall from physiology, we've got these areas of the brain, which include the SFO, OVLT. These areas of the brain are sensitive to osmolarity, and when they sense osmolarity dropping, they stimulate the PVN and the SON of the hypothalamus to release vasopressin from the posterior pituitary. And vasopressin causes increased water reabsorption at the kidneys. The SFO and the OVLT also will stimulate thirst if they sense a rise in osmolarity. Okay. Now, angiotensin II also acts on the SFO and OVLT to trigger the same things. Okay. So we know that we have more angiotensin II during pregnancy. Okay. And HCG also seems to be decreasing, making the SFO and the OVLT more sensitive to plasma osmolarity. So it tends to decrease the osmotic threshold. So mom is retaining more water, right? Releasing more vasopressin, retaining more water, and is more thirsty. Okay? Which both the thirst and water consumption and the increased water reabsorption is going to result in increased water retention. Okay. So I'm going to actually stop there, and I will discuss this slide in class.